It was in '94 that Tennessee received a waiver, an 1115 waiver from CMS to do a public option health care. Now, the interesting thing about this is that this did not go through the Tennessee General Assembly as an agreement. This was an agreement between the executive office, the governor, and the CMS, the federal government. So they set the program up. Thereby, your State House and State Senate were not allowed to participate in tweaking or changing the program. So what happened was you had a program that ballooned and mushroomed and grew out of size. Through the course of the debate on Obamacare or PPACA, what I repeatedly asked of Secretary Sebelius was, is Tenn Care, are you going to use the Tenn Care model for public option health care? Well, the only response we ever got, and the only response in writing we ever received on that, was that in her opinion, Tennessee was not a traditional public option plan. So our question was, well, Madam Secretary, what is a traditional plan? If it's not Tennessee, if it's not Massachusetts, both programs that you can say failed because they did not meet their objective. If it's not the National Health Service in England, if it's not the Canadian plan, what's a traditional public option? Well, what we all know is they did not have an answer to that, because what they wanted was government control, and their theories said if we control it all, we can make it work. But in practice, there had never been an example where they could control it all and make it work and have better outcomes and do it at a lower price. So what we have done over the past few years is to group together basically the lessons learned from Tenn Care and the lessons we wish that Secretary Sebelius and the President and his staff and the czars would have taken from the Tenn Care experience. Lesson number one is that free care is very expensive. It is incredibly expensive. And when you look at what happened with Tenn Care, which was the gold-plated plan, everything was free. It didn't matter if it was a prescription or if it was an appointment with the ophthalmologist, all free. So you take this gold-plated plan, and what we saw happen with Tenn Care, with the population, the universe of individuals covered, which had gone at its beginning from just under 1 million people to a high of 1.4 million people, but we saw the cost quadruple. And where the cost was to come down, it was never to have cost more than $2.5 billion. That was to have been the cap. But what happened was that ended up being the floor. And by the time the program grew to its height, it was $8 billion a year. It was 35.3% of the state budget. And that is the size that that program grew to, because what had happened, you had incentivized the use. And everybody had their health care card. One of the problems was that many employers in the state preferred free care to private care, because they could have their employees get a letter from an insurance company that insurance was not available, or that they were uninsurable, and then they went into the Tenn Care system. So they liked that. It was a magnet for drawing people into the free care off the private rolls, and we saw that diminishment and saw the growth in the rolls. One of the things that became a very painful lesson in Tennessee was the distinction between access to the queue and access to care, because we had some protocols where an individual would say, well, I have my Tenn Care card, I should be able to get this. And maybe it was a specific need or special services that a child needed, or some specialist that an adult needed, and they would end up having to travel 3 or 4 hours to see a specialist that would take Tenn Care, because after a few months in process, Tenn Care was running 90 days late, 120 days late, 180 days late on paying their bills. So what our citizens realized that they had access to the queue, but they couldn't see the doctor. And that there is a big distinction in that it led to court orders, it led to consent decrees, it led to people being slashed from the rolls. So those are primarily the major lessons that we learned from Tenn Care. It didn't surprise us when we saw what was happening with the SGR and reimbursement rate to doctors, because we saw Tenn Care want to come in and reduce what they were paying because of increased usage and because the price was going up. So what physicians are facing right now did not come as a surprise to us, because when you have that incentivized use and you're trying to do more with less, this is the classic of what ends up happening.